This conference will now be recorded.
Hi, everybody. This is Len Sierra for ANCAN, the video chat for the Advanced Recurrent Prostate Cancer, June 19, 2023. We want to acknowledge and thank our sponsors, which Dr. John Antonucci will read off right now.
Rick, correct me if I'm wrong, but I've got Bayer, Pfizer, and Myriad, Myovant, Janssen, and Telix, and Foundation Med.
And we just added, but we don't have them there, we just added Blue Earth, who make the Axiom scan and the new Posluma. Is it Posluma? Is that it?
Yeah, Posluma.
Yeah.
Yeah.
All right, gents. Let us begin with, let's see. I think Jerry Pelfrey was the first one who said he needed time. Go ahead, Jerry.
All right. Just to give you a little background, because I haven't talked about anything for quite a while. I'm 4.5 years into this on Zytiga and Eligard and prednisone. Last year, I was at about a 2.6, 2.7 PSA, and we did a PSMA scan, and we found a very active spot at L4. So I had spot radiation up in Mayo on L5, L4, and L3. After that, my PSA obviously went back down, and I've been following it since then. And the last one I took before we moved was 0.09. Today I found out, talking to my local onc, that I now have 0.2 PSA. So we were discussing whether to stay on Zytiga, because it already showed that it wasn't as effective with that spot radiation, and now it's showing it again. So thanks to Len, I brought up darolutamide, and he was all for it. He says with his patients, he starts them out on darolutamide now if they're doing if they're not just on Lupron or Eligard. But anyway, the discussion turned out that we did a test. I don't know how many of you know about an ARV7 genetic test. I'm sure you know, Lynn. And so we did that test, and we haven't gotten the results yet. And from what I was reading, if I have ARV7, then we need to really hit it hard, because the statistics are not all that good, because the cancer, I guess, uses this ARV7 as a growth spurt. So if you're negative, you're okay, but if you're positive, you've got to get going on it. So I don't know what I am yet, because the test results didn't come in yet. But our thought is, I'm going to Mayo in September for my yearly with Dr. Singh, and he and I will discuss what's going on. And I'm really leaning toward just dropping Zytiga and going to the darolutamide. So that's where I'm at. And I really don't know whether other options, I guess. I mean, chemo is always there, and I haven't had chemo yet. but I'd actually like to stay away from that as long as I could. So if the darolutamide will work, it looks like that should be my next step. Anybody have anything different?
Well, Jerry, the ARV7 splice variant typically confers resistance to enzalutamide and abiraterone. To be honest, I'm not sure if it also would cause resistance to darolutamide, but I guess maybe you're about to find out, or maybe someone else in the group knows. Is ARV7 conferring
Len,
resistance to? Go
I
ahead.
thought it was only. I didn't think it was to abiraterone. I thought ARV7 was only to enzalutamide and apalutamide, but I could be wrong.
No, the literature says enzalutamide and abiraterone.
Oh, then Len's right. Okay. But I
There,
mean, the fact is that since you've been on the abiraterone for so long, why would you have a splice variant now unless it's morphed? I mean, usually they test for that at the beginning. I mean, we haven't
Right.
talked about ARV7 for years, but at one point when these second line anti-androgens were coming into regular play, people used to test for them on a pretty regular basis. But I did think, when you say the literature, what literature said that it was that you wouldn't respond to Abby?
Well, I Googled, and I didn't go to just one site. I went to 3 different sites, and
Yeah.
all three of them had abiraterone and enzalutamide. That's
Okay.
all I can tell you right now, Rick.
No. I'm sure you're right. I mean, it's such a long time since we've talked about it, but it just seems to me that if that's the case, I don't understand why your guy's testing you for ARV7. It doesn't make a lot of sense to me. I mean, you might want to
Well,
ask him because
it's going to be able to prove that Zytiga has been compromised by the ARV7, or it has not been compromised by it, and I'm just it's time for me to move on. I don't know.
right. Well, but I guess my understanding of ARV7, and maybe Ben or Len or Dr. John can correct me, but my understanding is that if you have that ARV7 splice variant, it's there up front. It's not something that arrives halfway through. So if you would have had the ARV7 splice variant, you wouldn't have responded to the abiraterone.
Right.
no. That's not my understanding, Rick.
Oh,
I
okay.
always thought that it was primarily a treatment emergent mutation to therapies from Abby and Enza. Although
I don't
some
know.
people are, ARV7 positive out of the gate, but mostly it's treatment emergent.
Okay.
That's what
Okay.
I
Well,
read.
Yeah.
That's what I
that
read.
it's treatment emergent is
Yes.
what you read.
Yep.
Okay. Then I'm
I've
learning
got
something. That's great.
this is John. I've got an old Ambrx study from 2014.
Yeah.
It says detection of ARV7 in circulating tumor cells. This is 2014. He's writing about circulating tumor cells
Right.
from patients with castration-resistant prostate cancer may be associated with resistance to enzalutamide and abiraterone. These findings require large-scale prospective validation, and I don't see any more recent large-scale prospective validation in my quick look here, but it looks like there might be a little difficulty with enzalutamide, and it doesn't explain here why he would have responded so well for a few years to Abby and now is resistant to it.
Well, Len's saying, and Jerry seems to have found that it's treatment emergent, but
Yeah.
that but that's a new one. That's a new one on me.
Yeah,
What are you finding?
I think we
What's
haven't heard much about ARV7 in the intervening years because the thought was that, hey, this is an expensive test to run to check
yeah.
for the ARV7 mutation. And will, if the patient is resistant to or becomes resistant to enzalutamide or ABI, we'll move on.
Yeah.
I'm not sure it mattered if you had the ARV7 or not.
So I guess the question is whether to skip daro in favor of chemo or give darolutamide a try.
Yeah, that's what I was thinking, that I'd like to hold off on chemo as long as I could.
Yeah.
But
Yeah. But again, I don't think that's a great um, strategy anymore. I'd love to know what the group thinks about that. I listened to that ODAC study, that ODAC presentation, and Dan George got up and Neil Shaw got up and said, well, men don't want to do chemo anymore. And so this combination is great. But the fact is that most men now are doing chemo earlier, that earlier chemo seems to be better. And to put it off and put it off, um, it doesn't have the best results. I don't know. I mean, in terms of sequencing, I think most people. I think that with your diagnostics back in 2018, they probably would have put you. If that happened today, they put you on chemo immediately.
yeah, that may be true. I don't know. But that's why I'm waiting for Dr. Singh. And, if he says chemo, I go chemo. I mean, I'm not that opposed to it.
Right. Well, when are you seeing him, Jerry?
August 24th.
Well, I wouldn't wait for 2 more months. I mean, I wouldn't wait another month and a half. I mean, these are decisions that need to be taken, and I think you have to call him. I mean, this is why I think it's a problem to see him just once a year. I mean, if he's your quarterback and he is the GU medical oncologist that you think is guiding you, you got to be talking to him more than once a year, because this is a perfect example why you're at a treatment decision point,
Right.
and you want the best input at that treatment decision point, and to wait 6 weeks is not something I would do. I don't know what do other people say about that.
Jerry, there are several androgen receptor mutations that, other than ARV7, that can cause resistance to enzalutamide and abiraterone. But there's been at least in vitro evidence that darolutamide is effective against those AR mutations. I can put them in the chat. It's a little complicated, but so
Well,
go ahead.
that's
I'll open it up to everybody else. I'm just going to put this in the chat.
Okay.
guys,
There's a
what we got a big group here. Somebody must have some opinion. Who would wait 6 weeks in this situation, and who would reach out right now? George Savier, Dr. George, speak up, please.
Hi, guys. Well, I was 50 when I was diagnosed with metastatic disease, and I was at the point where they did this first studies with the chemo and the combining chemo and androgen receptor, androgen antagonism, and I this showed quite a bit of survival, increase in survival, and so it was a no-brainer for me. I had metastatic disease, and I took everything I could get. And luckily it worked out for me because I got everything up front. And I'm at the same. I agree with Rick. I mean, why would you wait? I mean, this is you're at a point, advanced disease. Any other cancer, they would be talking to their oncologist once a week. So I don't know why they sometimes treat this disease like it's come back in a year or 6 months. Somebody with active disease. I had I had kids. So I mean, I wasn't like 70 or 80 years old. I was 50. So I guess it was kind of easy for me, but I had to find doctors that were willing to work with me and just you find a doctor you can trust, and then you just trust what they say, and you constantly call them. I mean, listen, I totally am a firm believer in you know reaching out, and you know what, if you bother them, too bad. I mean, if they if they don't like to be bothered, you get another doctor. But I mean, um I just think the more the better. I guess I Dr. Myers. His approach was, if one is good, two is better. I mean, it's just there's more of a chance of survival. And my disease was put in remission, and it's remained in remission. So I guess I might be one of the lucky ones, but I think my approach is always looking out for my interest, and so that's kind of my 2 cents.
All right, thanks, George. Dennis Correa, you had your hand up.
Yeah, I just want to, Jerry and I both see doctors up there, and basically I'm on the same schedule once a year, and then I see my local oncologist that he works with. He set me up with for my regular blood work and my enzo or enzalutamide, not the enzalutamide, the Lupron, and the AbbVie prescription. But I had something unusual happen. I mean, I use my local guy basically as a convenience to get my routine stuff done. I don't rely on him for any other additional suggestions for stuff. I go to Sing, and he is reachable through the portal. And that might be a first. That's the easiest approach that I have to get in touch with him is through the portal, the Mayo portal. Might try that, Jerry.
Well, that's what I've been doing. I keep him or his team abreast of everything that goes on, with our local guy, Dr. Bajaj, and all my test scores. So I understand, and I'm going to get on it right away tonight. I'll let him know everything and see what he says. But yeah, for some reason, after 4 years, it seemed like Singh, he was quite relaxed with, okay, we can go to a year. But this is the first time I've done it, so I may go back to 6 months, especially right now. So we'll see. But thanks, Dennis. Yeah.
Okay.
So, Jerry, if Dr. Singh recommends chemo, ask him about a reduced chemo or docetaxel dose. Dr. Sardor, in a presentation he gave back in May, stated that he routinely gives docetaxel every 2 weeks at 50 milligrams dose instead of the traditional every 3 weeks at 75 milligrams. And he's noticed less toxicity and equivalent efficacy with that regimen. So talk to your doctor about that if he recommends chemo.
Yeah, thank you. Good idea.
Then another thing is cabazitaxel. Most guys find that to be a little easier to tolerate than docetaxel. So
Oh,
you can
really?
talk to him about that too.
Well, I just glanced at something about cabazitaxel. How do you say it?
Cabazitaxel.
Yeah. And I was wondering about that. So yeah, I'll.
So the story with cabazitaxel is that originally it was approved as a second-line chemo after docetaxel. And I think it was approved somewhere around 2013 or 14. So if it's your first chemo, it's technically off-label. It's not approved. However, there are a lot of doctors, GU med-oncs, who will give it to you if they feel that if they feel there's good reason. And in most cases, I think I can only think of one case where it's been as bad or more toxic than the docetaxel. So it can happen, but in most cases, it is a lot more tolerable. Now, could you follow docetaxel with cabazitaxel? Could you follow cabazitaxel with docetaxel? I'm not sure. Ken Anderson, I mean, what's your take on docetaxel versus cabazitaxel? Because there's nobody more experienced than you on this call with that one.
Well, there are no hard, fast rules. I mean, you could definitely do cabazitaxel first. So that's my comment.
Okay. So ask him.
Yeah, I will do that.
But
And
ask
Jerry?
him. I would not bring that up with your local guy.
No.
Because your local guy is going to say, "Oh no, you've got to do docetaxel first." But with Singh, you may get a better response.
Yeah. No, the local guy is out of this picture. This is between Singh and I now.
Okay.
Thank
Jerry,
all of you. Thank you for your input. Appreciate it.
John. I just want to add, Jerry, that my med-onc says 0.2 is the time to move. I didn't calculate your doubling time on the fly as we were going by there, but I agree that 0.2 is the time to move.
Yeah. Actually, a month ago, it was 0.09. So it's been 1 month, and it went from approximately 0.1 to 0.2.
So that's your doubling time. So go.
Yep. Yeah, I understand.
If you can count
and
doubling
Jerry,
time at those low numbers.
Yeah. What?
And
Go ahead,
Jerry,
Peter.
Len's point about Dr. Sartori using a lower dose twice a week rather than every 3 weeks for chemo. Make sure Singh knows it's Sartor because he's now at Mayo as well, but he's at the big Mayo in Minnesota. So he's moved
really?
over there. So Singh might have a lot more respect for that if it knows,
For
if he
Sartor?
knows it's from Sartor. Yeah.
All right. Good. I appreciate that. I'll say that.
Yeah. And
Thank you.
Sartor also said he occasionally will use a still lower dose, 25 milligrams, every week. So it's 1/3 the dose, but 3 times as often.
Yeah.
With the idea that it's less toxic, easier to deal with.
Easier to handle. Yeah.
Yeah.
Okay.
All
Thank
right.
you all.
Thank you, Jerry. I have David Muslin up next. Go ahead, David.
All right, so just following up from last week, my fatigue seems to have gotten worse, and I was thinking about it yesterday. I'm also on 20 milligrams of tamoxifen, and I wonder if that's having any impact on my fatigue. And I'm so fatigued, I'm thinking about just getting off everything and just taking a drug holiday. Just to give everybody back up a little bit of history here, I've been on 1,200 milligrams of darolutamide now for about 15 months. And PSA has been undetectable. And I really did pretty well up until about 2 months ago, about a month ago. And let me add one other piece, which even complicates it. I was on a high dose of prednisone, um, and I slowly tapered over 4 or 5 months, and I just finished 2 weeks ago. I just finished my prednisone, so I'm wondering if that's not having an effect on my energy as well. So I know I just put a lot out there: prednisone, tamoxifen, darolutamide, and I just thought I'd get some input, guys. Sorry to if I'm all over the place. Sorry about that.
I get 4% for tamoxifen and fatigue.
4%.
Yeah.
Okay.
I haven't seen any men on it, but I've seen a number of women on it, and none of them complained of fatigue.
Yeah.
But
Well, I
I
can,
know that people get a lot of manic energy on steroids.
Right, but I slowly, it's just me. I slowly tapered on prednisone. It was actually, I came down 2.5 milligrams every 2 weeks. And I probably started at 40, and it took me months and months to come down.
Yeah, that's good. Slow.
Slow like a pro.
I
But
I would definitely I definitely speak to Dr. Shmulewitz about the impact of the steroids.
so
Um,
I did, and I was
Go
communicating
ahead.
via my chart today, and let me tell you what he said. Just bringing it up here real quick. I proposed the same question. He also doubted that it was the darolutamide, I mean the tamoxifen. He thinks it's the Dara, and also threw out the thought of possibly taking a drug holiday. And what he said was, you can hold the tamoxifen, although I doubt that's it. If that doesn't help, then I'd hold the Dara. We can decide to hold completely and follow with PSA testing and repeat PET and PSA rises or restart at a lower dose. So, as he's just kind of saying, whatever you want to do, I think I'm good with. But I'm thinking about maybe just taking a drug holiday for a while. Len, you came down slowly, didn't you?
Off of Darrow, yes. I first went down to a half dose and then to a 1/4 dose. Um, and it did improve the fatigue. And eventually, when I dropped it completely, the fatigue pretty much vanished, as it did with Peter Kafka, also, I believe.
Right.
Um, so
So
if you do go on a Darrow holiday, you won't need to take the tamoxifen anymore either.
right, right.
So I, that talk to your doctor about that. I think that's a good option to go on holiday.
Yeah. Go on holiday, or should I, taper down like you did, Len, and slowly come down, or should I just stop it all and just take a holiday?
I
I'm not
just
sure. I was kind of self-medicating. I don't know how smart
Right.
that was, but yeah, talk to your doc if it's okay to just stop it right away.
My guy
Yeah.
just had me just stop my Darrow. Boom.
And were you struggling also, Dr. John, with terrible fatigue?
With moderate fatigue at
Moderate.
the time, but that was 3/4 of a year ago, and I have much more fatigue than I did when I was on it in my case. And I think that just the number of years without any AR activity going on at all, I think it kind of accumulates. I don't know what the other guys think, but I'm just half dead with fatigue now, and I'm not on anything.
Wow.
But I got no T. What's your testosterone level? Probably nothing.
No, my testosterone is like 400, 500.
Oh, oh,
So, John, your T level is still low, even after
not
being off meds?
undetectable.
Huh.
T level, he's asking. Testosterone, John.
Yeah,
I
Yeah,
non-detectable.
T level, right? So,
Yes, yes,
yeah, that could be causing your fatigue, even though you're not on meds.
yeah.
Your T
I
levels,
I think in my case that's what's going on, but
yeah,
obviously not in David's. But no
no,
matter how much T he's got, that Darrow is in the way of the AR receptors.
yeah.
Mr. M, what did you read what Shmulewitz said, but did he mention the steroids in there? I heard him mention the other stuff. What did he say about the steroids?
Let me go back and tell you what he said. Um,
Yeah, hey, this is George. How much prednisone were you on?
I was
Well,
on, I started at 40 and slowly came down.
Yeah, sometimes I mean if you're on that much, it can suppress the adrenal glands,
yeah.
and then when you start coming down, your body has to start making its own again, and you get kind of like a withdrawal. You have all this energy when you're first on it, and then when
Right.
people start coming down, your adrenal gland has to now start making it again. So that that can do a number on your fatigue.
Yeah.
Yeah,
So
that Dr. George, that was the line I was thinking. So I was, David, did you find what Dr. Shmulewitz
yeah,
said?
earlier this morning he said it very well could be the darolutamide or coming off the prednisone. If the
Okay.
prednisone, I'd expect your body to adjust. If it doesn't get better, only option is to hold off on the darolutamide, to hold the darolutamide. So
Um, I would ask if there's any tests they can run to determine if your adrenals are sluggish. Dr. George, are there tests that you can run for
Yeah, they
that?
can do what's called it's called an ACTH. It's a type of test where you get a drug, a hormone, and you see what it does to the cortisol levels. And if the cortisol levels don't come up, then it's probably the adrenals. It's called a
Dexamethasone
cortisol
suppression test.
stimulation test or something. Yeah. Um,
I'm
that that
challenging. I'm challenging you, Dr. George. You haven't had to
yeah.
think about this in a while, right?
No, well, you could take a nice dose of prednisone and see what happens too. I mean,
Yeah.
Well, that's how they do the challenge with dexamethasone.
right, right, and I mean, that's the first thing we do in the emergency room if somebody comes in with adrenal insufficiency. You give them 100 milligrams of hydrocortisone. Um, but I mean, there's so many things, so many factors, like you're saying, the testosterone levels, and there's so many reasons why you can have fatigue when you're on multiple medications. It's tough to narrow it down, but and steroids are pretty potent things. That's why they don't like to have you on them for a long time.
yeah, but again, I got off it very, very slowly. 2.5
Yeah,
milligrams every 2 weeks is what I came down
yeah,
slowly, slowly. So, but maybe it's worth taking that test. That may identify the fatigue. If it's the prednisone is going to take a while, then maybe that's it. But I'm also getting tired of the hot flashes. I'm just kind of getting fed up with everything. I'm thinking, you know what?
yeah.
Fuck it. Let's just stop everything for a while and see what happens. But I know that's not the smartest thing to do.
I think it's reasonable. It's logical.
Yeah, it's
Yep.
It's understandable.
Hey,
If you
one
get a
question,
Depo-Provera
question,
shot, if you
question
get a
for you, Len.
Depo-Provera shot, it will really greatly reduce your hot flashes. There are other options, but I know it does an incredible job for me.
Yeah. Depo-Provera, right?
Depot Provera. I'll put it in the chat window.
Yeah.
Okay.
I've been on it for about 4 years, and I'm able to wait. It's a 3-month shot, but I've been able to go 4 or 5 months with it, still keeping my hot flashes way down.
But
Okay.
you can't get pregnant on it.
There's a couple of new drugs too, but only approved for women. I wish somebody would do a study with men.
John, how long have you had your T level low while you've been off of other drugs?
3/4 of a year.
Wow. All right. My brother was mentioning his isn't coming up, and that's why I asked. He's 77, and I think age is a factor.
Yeah, yeah.
I started taking what's it called, venlafaxine, a couple months ago, and it's greatly reduced my hot flashes. It's an antidepressant.
Oh, affection.
Venlafaxine, which is a
Yes.
drug I'm very familiar with, Harry. I've been on it since 2000. Unfortunately for me, it didn't help, but it is known to help hot flashes. I think in my case it was because my body was already accustomed to using to it, so it made no difference. But yeah, venlafaxine can help.
Yeah, it's
It's
made
also,
a substantial difference in me. Like
that's
it's
great.
really incredible. Yeah.
It's an SNRI, which is an antidepressant, and Dr. John can probably, or Dr. Jack can probably speak more to venlafaxine than anyone else. So.
All right. Well, I think I've got enough for now, guys. I appreciate it, and I'll do some more work and I'll let you know what I learn. Thank you, everybody.
Okay, thanks, David.
I
We're
bet I
going to
know
go
what
to,
I was going to say. I bet I know what Dr. E would do with him. He'd get rid of the drug.
Yeah,
You say take a holiday?
yeah,
I bet you.
yeah, yeah, yeah.
Remember Russ? Is Russ Hoover here? He's not here, but oh, there he is. That's what she did with Russ, and he felt like a new man.
Yeah. But obviously, the fear is, the PSA starts to rise, and it's been undetectable for so long that I don't even
Absolutely.
worry about it anymore. But it's,
So,
but I'm worn out here.
so
Absolutely.
David, you just test every month. Keep a close
Yep.
eye on it. You test
Yep.
your PSA every month, and if it starts to come back, we huddle.
Yep. Yep. Absolutely. Thanks, gents. I
all
much
right,
appreciate
Pat
all your help.
Martin, you're up.
There. It's been a while since I brought everybody up to date. I had a PSMA scan tested to evaluate for Pluvicto availability, eligibility, and I am definitely avid. Um, it found spots that weren't found, and um, I could go through it, but several pages of the same. So next time I talk to the doctor, probably a week, within this next week, he'll get me lined up on Pluvicto and go with that. So that's
Okay.
the update.
Anybody have comments for Pat?
So a couple of things, Pat. First of all, when they did the PSMA, did they also do an FDG to see if you were concordant?
I had one of those about 3 weeks before, and they compared in their notes. They compared back and forth, and they correlated to each other, and it was good.
That's really great. So
Yep.
the second thing is that you should experience no delay with the Pluvicto. If you do, please let me know and we'll chase it down. I had one guy last week who told me he had a delay, and I pushed him, and I think the delay was probably coming more from him, that he hadn't asked recently and was reporting that there was a delay. As it turned out, I think he's starting this week. He got scheduled. So from what we can gather, we're back to no wait lists, and you shouldn't have any issue getting your Pluvicto.
Yeah. I asked Dr. Schweitzer about Ambrx, a similar drug, but it's not a radionuclide. It's just it attaches to the PSMA and injects chemical toxins into the cell. And he said the way that is they start you on a very low dose and then gradually bring you up to speed. And that's not what he's wanting to do. He wants me to bring to speed right now. So it would surprise me if he waits any time at all. He's one of the He's one of the testers up at UW Med Center, and so
Right.
he's very willing to get me in fast and hit it hard.
So I'm not familiar with Ambrx. I mean, I'm familiar with that maybe I'm using the wrong terms here. I've got to be careful because otherwise Ben's going to send me rude notes. But the bi-specific, or that where it has is attracted to PSMA at one end and there's a chemo payload instead of a radionuclide payload. But I don't think anything's approved. Tell us about this Ambrx. I'm not. Anybody else aware of Ambrx?
I just looked it
That's
up
got
and
to
got
be in clinical
nothing.
trials only.
Yes,
Yeah.
it's in
It is
trials.
trials only. The ones that they release the results are very, very promising, very promising.
But
Okay.
it's got a brand name already?
I think Ambrx is the company, John.
Yeah,
Oh, oh,
AMBRX.
thank you.
Yeah, no, I've definitely heard of the treatment, but I haven't heard any results. But yeah, I mean, I would, if it was me, I'd follow exactly what Dr. Schweitz is saying and start taking that. How are you doing with your how are you doing with your where's your PSA and your markers and because your
They haven't
blood counts were horrible.
checked my huh?
Your blood counts were horrible for a while there, weren't they?
Yes, they still are. They still are. My PSA, they quit checking it, to be honest with you. And I don't know why. I've asked him, and well, we know where it's at. No, I don't. Not without testing. And kind of got a little snipey with him, but we'll see. I'll ask him next time when they check my PSA.
Have they? Did they ever do any checking to make sure that your disease isn't morphing?
They have they did a check for um, brain fog has emptied my brain. Neuroendocrine. I am not
Yep.
neuroendocrine.
Oh, good.
Um,
Okay.
yeah, so that's one good thing that they found.
Oh, great. Okay. Great. 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 All right. Well, keep us posted. But the thing is, they've got to, Pat, you've got to do a PSA before you start because you need it as a benchmark.
I'm
Don't
sure they
let,
do.
yeah.
I'm sure they will, Rick.
Okay.
All right.
Ambrx stock rose 45% when their phase 1 trial results came out.
Yeah,
And PSA dropped 90% in 2/3 of the patients, it seems.
Yep.
Well, keep in mind,
Very small sample, but it was very,
phase one is usually about 10 people or so.
yeah, very small.
All
I think
right,
they, oh, go
Pat,
ahead,
thank
Lynn.
you. Good luck.
Thank you much. Thank you very much, all.
And we're going to go to Salvador.
Hi, I might have just found my answer. I'm about 2.5 months into my treatment, which has been radiation and hormone treatment at UCLA, and the last 10 days have been a complete nightmare. Body flashes, just complete exhaustion. I did talk to my doctor and asked him about what I could take for that, and they recommended venlafaxine, but I looked up the side effects of it and I
Venlafaxine.
spoke venlafaxine. I looked up the side effects of it and spoke to a couple other guys, and they said it's horrible. They said they had nothing but horrible results, even worse than, not worse, but about as similar as what the hot flashes that they were having. Mine have been debilitating. I mean, I haven't been able to work. I haven't been able to basically leave my house for almost 10 days. So this Depot Provera, that might be something to suggest to the doctor.
It does
Not
take
sure.
10 days
Having a little.
before it does take 10 days
I'm
before
sorry.
you finally feel the effects, by the way, but it lasts
He said
3
it takes
months.
10 days to feel the
Which
effects.
one? Okay, got it. Another 10 days.
Okay, so
I'm about ready to
there's
go for my second
so there's a
hormone shot.
yeah there's a lot of issues here, Salvador. First of all, everybody responds differently to the antidepressants. I mean, I first was put on an SSRI, and it made me suicidal. Now, I was taking this for depression. I wasn't taking it for hot flashes. And when I eventually got off of that, I mean, I was on it for 2 weeks, and then I had to flush my body through and wait. And when I got on the SNRI, which was the venlafaxine, it was great. And I've been on venlafaxine for 20 years or more, and I don't have any side effects that I'm aware of. But I did from the SSRI. Some people get on SSRIs and they have no problem with them, and they have terrible problems with an SNRI. Again, Dr. John's probably seen that more times than I've had hot dinners, at least in the last month. And Dr. Jack's probably seen it too as prescribing psychiatrists. Depo-Provera is a drug that has significant side effects. It's not for everybody. So is Megastrol or Megace. Both those drugs are around. There are a lot of GU medical oncologists who won't prescribe them. They're essentially similar types of drugs to Lupron, except instead of giving you something that stops your testosterone, they're giving you something that stops your estrogen. And one of the things that a lot of people I know have done before taking Depo-Provera or Megastrol is they've gotten a little radiation to their chest, because gynecomastia is a known side effect of those drugs. Also, there are issues around metabolic syndrome, just like there are with the LHRH, and it can exacerbate a whole bunch of conditions. So whilst I'm sure it works very well for Jeff, it's not for everybody. So it doesn't come, it's not a freebie. It doesn't come with no side effects. Now, there are some and I don't know if you've tried them yet, but there are other solutions that are less toxic. So you can, a bunch of the guys use the Amber Watch, EMBR, which works for some guys. It works fantastic, and that you wear it on your wrist, and it regulates some nerve on your wrist, and it seems to work. For some guys, acupuncture can work pretty well, but you have to do it every 3 weeks. And there are other solutions too. So have you tried the Ember Watch? Are you aware of it?
No, I've never even heard of it. Never heard of it before, but I was going to ask about the acupuncture because somebody this weekend recommended that I check into that.
So let's
So
first talk
I don't.
about the Ember Watch. Somebody who's had good results with the Ember Watch. Do you want to explain it to Salvador? Tell him what you're doing.
I can
Yeah,
do that. I have an Ember. It's not a watch. It's an Ember device that looks like a watch.
Yeah.
It it gives you very cold feelings on your arm, which could flow through your body. MIT invented this, and they produced a product to do it. And as long as you're not getting really severe hot flashes, it works great. But I know for me, when I'm not on the Depo-Provera, at least within 4 or 5 months of it, it doesn't work as well, and because I get much more severe hot flashes. By the way, I have had 0 side effects from Depo-Provera, absolutely nothing. Just so you know, there's different results with different people, but I've had nothing. But the Ember device works really great if you're not having really hard hot flashes. You can hit the button on it to start it immediately when you start feeling a hot flash, and it will pretty much stop it from coming on. As long as you're having not too severe ones, that will work. And you can get the device. It's around $300 because they give you a discount on it. You can get the device, and you can have a 30-day trial, so you can send it back if it doesn't work for you.
Good to know. That's great. Yeah, my hot flashes have been very, very severe. I mean, just a complete wipeout for me.
The other thing I noticed with the hot flashes was that the minute they came on, I had this severe fatigue, and then I get the hot flash. I don't get the fatigue anymore because between the Depo-Provera and the watch, it doesn't happen. So that may be one of the reasons you're feeling that fatigue. It sure made a big difference for me.
So I can speak to the
Thank you. Thank you for sharing.
I can speak to the Ember
Go ahead,
Wave.
Bob.
Well, before I do, the other option besides Depro is estradiol patches,
Yep.
which potentially might have less side effects systemically, though you can still get gynecomastia. For the Ember Wave, for me, if it's a minor hot flash, it works great. And like Jeff said, the big ones, not so much. I wouldn't call it a game changer, but it definitely helps. In my case, at least.
Okay, great. Thank you. Thank you
Sure.
for sharing that.
Sal, I put the link to the Ember Wave device in the chat. All right.
Great. Thank you.
And we get a discount. I think I always get this wrong, so email me.
When I bought it, not maybe 3 months ago, they said the discount had expired, but they gave me a one-time thing. So you can ask about the discount. They may or may not.
Yeah. Okay. So that's another job. We gotta reach out to Ember and get them to reinstate that discount. But try it.
So
Bob,
what about the acupuncture?
So I
like
tried
everything
acupuncture.
else, it works for some and doesn't work for others.
Yeah, I tried acupuncture
Okay.
both for hot flashes and for neuropathy. And I found I got better results with the neuropathy, though didn't last. I had to go every 2 to 3 weeks. And you know, one of the worst things is laying there with pins all over you and getting a major hot flash, and that happened a couple times.
Hey, Salvatore, this is George. Did you have a spinal cord compression, or you said you had
No,
neuropathy?
I
Oh, my
no,
neuropathy
I
is from
haven't had
chemo.
neuropathy at all.
Yeah, my
Oh, okay.
neuropathy is from
Yeah,
chemo.
I only had radiation.
Sometime I had the spinal cord compression, and I took gabapentin, and as a side effect of the gabapentin, I noticed that high doses help my hot flashes for whatever
Yeah.
reason. I don't know. It's some people say it helps. A lot of people say it does nothing, but I know the high doses help me with both actually.
I take
Okay,
600
the
milligrams
gabapentin.
3 times a day, and it doesn't help my hot flashes at all.
Yeah, yeah. I'm talking about high doses,
Wow.
like 800 4 times a day, that kind of dose. Um, but I had spinal cord compression, so I had to have the higher doses. There's not a lot you can do about it. I don't think. I mean, geez, I mean, I've tried everything too. It's a horrible thing, especially at night.
Are there, does anyone know if there's any natural remedies for the hot flashes? I get very leery of every time I talk to my doctor. Well, we could prescribe this, we could prescribe that. And then I go and look up
Right.
the side
There's a
effects
lot
of
of,
these things, and they're horrible.
yeah, yeah. So there are a lot of um, naturopathic, but we've not really found any that work. So you're going to find
Okay.
definite a whole bunch of different things that they're going to say, try this, try that, try the other. That's why I would start out with the Ember Watch and see how you do. Get
Okay.
yourself an Ember Watch. I think the other place, somebody said they have them at Costco now too, and you can get a discount at Costco. But I would start out with the Ember Watch. If that doesn't work for you, some people get lucky with the with with the um, with the acupuncture. Do you want to say, Dr. John? Do you want to say anything about the acupuncture?
Well, I agree with you, Rick, that that's a perfect order to do things because you go from the least toxic to the most. So I'd do
Yeah.
Ember first, acupuncture second, venlafaxine third,
Right.
Provera fourth.
Right. Have you tried the
Okay.
venlafaxine, or is it just that you heard from people that
No.
it's well? I mean, you're looking at someone that
No, it was
venlafaxine.
recommended.
Yeah, I mean, and so
My doctor
there's
recommended.
right, and you're always going to find if you go on. If you put it on Inspire or somewhere like that, there's always going to be, oh, don't touch that, and it's this, that, and the other. But you're looking at someone who had no problem, who's never had a problem. I take what do I take right now? I take 112 and a half extended release every day, and so d- don't be careful of Dr. Google and be careful be careful of these guys. It could do. I'm not saying it won't. You could have the bad reaction, but it's like the Depo-Provera. It doesn't bother Jeff at all, but there are other people who take Depo-Provera or Megastrol, Megace, and they finish up with big boobs.
Yeah. Yeah. So, as the other question I had is, as one continues to get these hormone shots, does this get worse as far as the side effects?
Well, the fatigue side effect tends to be cumulative. So you should be exercising, cardiovascular and weight-bearing exercise. Make sure you
Yeah.
do that so you don't lose your muscle mass and maintain bone density. As for the
Okay.
others, I don't think they get any
Okay.
worse. I don't know. Does anybody disagree with that?
I mean,
Learn to live with
I'd
them.
rather go ahead. Who was that who just spoke?
No, I just said, yeah. This is George. I think you tend to deal with it over time, and you
Yeah.
just accept it as
Yeah.
this is the way it is. I don't know. I mean, it's one of those things,
Yeah.
you have to accept. I mean, you got to be on the hormone treatment. So, um,
Salvador, I'm reluctant to say anything because I was only on it for 3 years, but we've got guys on here who have been on these drugs for 5, 7 years. So I'd rather they spoke up and said, does it get worse or not? Or even some of the guys who have been on but are on now. I was on a long time ago. I mean, Henry, I don't know. Is it getting worse for you, Henry, or is it has it sort of tabloid?
So I'm on Orgovix, and I started that and abiraterone November of 2021, and I'm 55 now. I was 54 when I started, and I'm a stage 4 guy, lymph node metastasis fella. And yes, to answer your question, it's plateaued, and I take venlafaxine. I moved up from 37.5 to I just doubled it at the suggestion of the oncologic pharmacist that I work with, and it's been wonderful. That and the 3 box fans in the room, which are awesome. but, but no, I mean, I would say Dr. George pointed out. I guess sometimes we have to embrace the suck, and you know, um, but it's made a difference for me. The box fans, the exercise, and the venlafaxine 37.5 times 2. Thanks, Rick.
I
Thank
was
you. We can call it Effexor. It's easier to say than venlafaxine.
don't forget the
Yes,
three
now
B
I
it
can
is
twelve.
say
for an Alabama guy like me. I was trying to remember. Hold on, venlafax. How do I say it? Yeah, Effexor. Yes, I much prefer that.
Rick, I
Okay.
have to say that
One
I
other
was on
question I have.
Lupron.
Hold on. Go ahead, John Bab.
Okay, I was on Lupron for 11 years. In the beginning, I had bad sweats, but they went away. And now that I've been on Extendi for about 2 years, I have warm flashes, but I don't sweat. So
Okay.
my experience is my hot flashes just kind of went away.
Okay. Thank you, John.
After
Go
how
ahead,
long?
Len.
That's hopeful.
Can I say something?
One of the
Go ahead, Jimmy.
Uh, there's no data for this. There's no evidence for this. I'm always talking about exercise and how much it's helped me. And at my worst on ADT, of course, it's known to help the fatigue. It's known to do many good things. I didn't have any hot flashes really. I had a few what I would call warm moments here and there. I can't help to think that increased circulatory health, um, carrying less fat, would have to be helpful in reducing the hot flashes. I think if you're carrying extra weight, particularly if you're carrying extra fat, and if you're not getting enough exercise, I would imagine that might exacerbate hot flashes. I have no proof of this, but I had almost no problem with them at all, and that was just my experience.
Salvador, you're not going to be on long-term stuff. You're doing it for radiation, right?
yes, I've already had the
Yeah.
radiation
Okay. So how long do they want to keep you on the ADT drug?
for 5 more months. Well, actually, 5 more shots. So it's every 3 months.
18
So a
months.
year and a half?
Yeah.
Yeah.
Yes.
Yeah.
So
You
the,
can
the other
handle
one
it,
other
man.
question I had was, yeah, I'm doing my best. I was speaking to another doctor who said that suggested that I talk to the doctors at UCLA about doing some estrogen also, because he said in his practice, guys, and he said my doctor would probably say no to it, at UCLA, but he said in his practice, he's had guys over the years, he's just retired, and he's given them estrogen, and they've never had a problem. It with the depression, with the hot flashes, with a lot of the side effects that comes with the Lupron.
So that's the Depo-Provera. That's the Depo-Provera. But again,
okay. That's the estrogen.
Yes.
Okay.
That's the Depo-Provera solution, or another one like that is Megastrol, Megace.
They also have estradiol patches too.
And estradiol patches, that's what, like Dr. Bob said. They're all in the same category.
Depo-Provera does not contain estrogen.
Well, technically it's progesterone, but it's female sex hormones basically, and
they're all in the same category. They're all in the they all work in a similar way.
Okay. So my conflict, and maybe somebody's had this experience, is that the doctors at UCLA recommend one thing. Another doctor who has been my best friend and doctor for over 30 years said, I get on the hormone things, and he said, but you should run it by your doctor. I ran it by my doctor at UCLA, and he said, absolutely not. It's not going to do anything for you. I'm torn about trying the estrogen, but I don't want to do something that's going to conflict with what the protocol that they're doing at UCLA.
Right. So let me give you, I do have an opinion, a firm opinion on this one, and you can ask the other guys. A lot of people, medical professionals, don't understand prostate cancer. They may be great doctors in their own area, but they're not prostate cancer doctors. We say you need a GU medical oncologist, or at least in your, I don't know if you've got a GU med onc or if it's the radiation oncologist who's running your show, but if you're getting treated at UCLA, then you've got a specialist who understands prostate cancer. And they're the guys, for me, who I would go with. Everybody else may have an opinion, but you have to choose your quarterback who hopefully is a prostate cancer specialist, whether they be a rad onc or a medical oncologist, and go with them. Because if you start crossing them up with other doctors, you may as well just kiss them goodbye. That's my opinion.
Yeah, no,
anybody else want to talk about this? This is an important topic.
My doctor recommended Depo-Provera to me, heart start.
Okay, but Jeff, you keep harping on this. It works for some people. Some doctors recommend it. Not every doctor. It works for you. We got it.
Maybe every doctor doesn't know it works.
Every doctor, every GU medical oncologist knows what Depo-Provera does.
And everyone has tried them on patients.
If they're a GU medical oncologist, they know what it does. The point is, not all of them want to recommend it. Sometimes some will, some won't. Okay, I can tell you, for example, Andrea trained under Eric Small. When I asked Eric Small, what should I do about my hot flashes, he said, take Megace, Megastrol. But there are a lot of other doctors who don't do that. So you choose your doctor and you go with them. You chose Andrea and you're happy with her. But you can't make the assumption that every doctor is going to have that same opinion.
And yet you are on here telling people you should direct your doctors what to do. You should not let your doctors make the decision in every case. That is one of your most important points that you make in this group. And yet here you are defying that by saying, oh, you should listen to your doctor only.
You've got to back off again.
You should also do it for yourself.
Off again. Back off.
This guy is miserable and should have some help. And Depo-Provera would probably do it.
Jeff, back off. Okay? I'm just telling you, back off. Now, yes, do we say on here, bring this to the attention of your doctor? We do. And the fact is that Salvador has brought it to the attention of his doctor, and his doctors don't like it. Now, he's asking, what should I do? Who should I pay attention to? I'm saying you pay attention to your GU medical oncologist, and if you don't like what they say, you find another GU medical oncologist. I mean, someone else should weigh in here.
Yeah,
Rick,
Rick, I want to weigh in. I want to weigh in, Rick, because I've been agreeing with you for a long time on this one, and this is one of the most important things in this program is the fact that once you pick your GU onc, you go with that, and you listen to what they say, and you have to trust your doctor, your GU onc doctor. You can't go to him and then go see your other doctors and go see your local oncologist, and because there are too many doctors involved, and the GU onc doctor has to make the final decision. That's what I believe. I had to get 4 consults before I found a doctor that I believed in and trusted. And sometimes you have to do that, but you got once you find that doctor, you got to go with that doctor. I mean, it's even harder when you are a doctor because you want to make the decisions too. And you know,
I
I
want to
got to
know how you're
agree.
doing otherwise. Other than the hot flashes, how are you doing?
Other than the hot flashes and the fatigue, which comes from right after the hot flashes, I get extremely tired. I'm doing okay. A little bit of depression, but I can handle that. Um, you know, having the hot flashes doesn't really help when you live in the middle of the desert. Also, that kind of goes with it.
I thought
What
that
I
dry
found
heat.
with
I
my
thought
team,
the dry heat would help you.
yeah, well, it hasn't helped very much. Thank God it hasn't been that hot yet either. But
Yeah,
one of the
I
things
get
that
some. Go ahead.
who I've been communicating with the most at UCLA is my radiologist and not the oncologist. And it's not even the radiologist, it's his assistant constantly. And I've asked this morning, I sent an email to Dr. Keyshawn and I asked if I can speak to him directly because I get nowhere with the assistant at all. And it's starting to feel a little uncomfortable to me. So maybe that's where I have to start is to contact my oncologist who works with my radiologist and have the conversation with him.
And it sounds like from the advice people are giving you, start with the least invasive thing, and maybe the Ambrx that'll be the first thing, and it'll work for you, and bing bang boom. Maybe
I'm
not.
going to order it today.
I totally agree with that advice from Dr.
Thank you.
John. Start with the least invasive, least toxic, and then move up from there.
Okay. Thank you very much for the feedback. I really appreciate it.
All right, guys, time to move on. Dr. Bob, you wanted time.
Okay, so real quick, my journey is about to change. So it seems like I failed abiraterone, and I'm going to be starting Keytruda a week from tomorrow. A week from today, I got my first PSMA PET scan. My PSA since January has gone from 0.48 to 2 weeks ago is 2.22. Fortunately, my scans have stayed stable, but once I went over 2, she's considering me castrate resistant. So question I have is tapering off the steroid since I stopped Abby. I'm just curious what people have done in terms of their taper. What she wanted me to do is a week taking 5 milligrams, and then the second week and beyond every other day. And then after about 10 days of every other day, she said I should be good. For people who have tapered off prednisone. Does that sound reasonable?
Yes, you're on a very low dose. Doesn't take long to wean yourself off of, what is
Okay.
it? What
And
are you
I've
doing,
only been
5
on,
milligrams a day? Yeah.
what's that?
What are you doing, 5 milligrams a day?
Yeah, it's been 5
Yeah.
milligrams. It's only been for about 6 months.
Yeah, it doesn't take long to get off of that. That's no big deal.
Okay.
It sounds kind of typical to me too.
Sounds typical. Okay. The only thing I'm a little concerned is pretty much I'll be done the taper right when I start Keytruda. So I might do the continue for another off and on for another couple days, just so that if I do get some side effects, I'll know it's not from the lack of steroid. So, okay.
Yeah, and the steroids could help if you end up getting any kind of liver reaction or something like that. They can modify it.
Right.
So I was on a very low dose of steroids because I was weaning myself off when I started. The other thing is, and Len will agree with me on this one, give the Keytruda time. Don't expect it to work magic the first 3 weeks or 6 weeks or 9 weeks or
Right.
whatever. Give it time. It takes, because it's working with your immune system, and the effects don't show up, and sometimes it looks like it's going backwards, which it did with me. But then it kicked in. So don't be surprised.
Yeah. Yeah. She has me for every 6 weeks. So, okay.
So, Bob, what was your TMB? Do you know?
Yeah, I was 23.
Yeah. So I think you were in that loop of emails that went back and forth where there was a paper that came out saying that the best uh, predictor of response to immune checkpoint inhibitors was the TMB value, and that the best responders were those who had TMB over 20. So I think you're going to be a real good candidate, as Peter is, for Pembro.
Yeah. Hopefully. I think I had sent in an email that I'd spoken to someone from Merck, and they felt that MSI high was equally important. So since I have
Yeah.
both, hopefully.
Well, both are important. I think we've known that for a long time, and you fit right in the sweet spot with the Lynch
Right.
mutation. I forget which one you have. Is it MSH6?
Yeah, I forget I have 2 of them.
2
Yeah,
and 6.
2 and 6. So and Dr. Sartor felt that just now he said he's got high hopes for you. So we've all got high hopes for you. The question is how you're going to react, and some people react better than others. Peter's done relatively well. One of
Yeah.
the issues that I don't think Peter went through too much is people getting rashes, having adverse thyroid
Right.
reactions, which we've seen.
Right. Colitis, I know, is possible.
So it's just a question of, we hope you're going to tolerate it well, and you're one of the few people that fits in the sweet spot, along with Peter.
Yeah.
I'm sure Peter but you guys have been talking offline, haven't you? The two of you?
Yeah.
Yeah.
Yeah. Somebody told me I got the golden ticket, but the golden ticket also gave me a PSA that went up tenfold in 18 months because of that. So, goes both
We're on
ways.
it. And one thing, you're not going to lose your hair, and I see all that hair coming back, Dr. Bob. Look at that, man.
Yeah.
It's looking good.
It's a lot different than it used to be. But hey, I'll take it.
Yeah. In the case of immunotherapy, Bob, as you probably know, when it works incredibly well. And there are prostate cancer guys who've gone undetectable for years, even after they stopped. So we're hoping Peter will be one of those, and we're hoping you will be too.
Yeah, I've spoken to one guy. He was diagnosed at diagnosis with neuroendocrine, and he's 8 years out, and he's
Wow.
still doing okay.
Wow.
Yeah.
This is kind of beyond my knowledge, but pembrolizumab can cause adrenal insufficiency, and he's going to be started on it right at the same time as he's at the end of his steroid taper. Now, it seems like a long shot. I don't know. Does anybody think that that could confuse the issue at all? The fact that the prednisone is so low and the taper is slow doesn't seem like it should make a difference. But
Yeah.
I don't know.
From
Should I
everything
worry?
I don't know. From everything I've read, it seems like when you start getting immune responses to other organ systems, other than maybe the skin, it tends to take some time.
John, when I for my second dose, I had a liver reaction. My liver enzymes shot up tenfold. They put me on 80 milligrams of prednisone for a week, and then tapered me off of that for the next 2 weeks and put me back on Keytruda under the doctor's supervision. I did fine.
Okay. So
Yeah,
just monitor closely for adrenal insufficiency. I
Oh
guess.
yeah, they're watching your blood really
Yeah.
carefully on this one.
Okay.
Okay, thanks.
Okay, thank you, Bob. And Neil, you had a question, you said, for the group?
Yeah, hi. Yeah, one of the things I've been going back a little bit with Rick and I have had a little talk about kind of supplements, and I've had a lot of information come from all kinds of places, of course, with their recommendations. But one of the specific supplements that we thought might be of interest for discussion is has anyone heard about pectin and how it can affect your treatment, and particularly galectin-3. There's a study that was done by a doctor in Israel, and apparently he produces this and sells this. So, who knows how those studies could have come out. But has anyone heard about pectin or experimented with pectin, and have any, is there any discussion around it?
So I guess I'll weigh in. I've been using off and on modified citrus pectin, which
Yeah.
I had read about, that can supposedly help with reducing the chances of metastases. Whether it works, I don't know. The only downside is it has a decent amount of salt. That's the only downside I can see. I just mix it with, my hot tea. But I don't know if there's some science, but I don't know how great it is.
Yeah, I think that's kind of, it doesn't seem like there's a lot of studies on it outside of what this one fellow has done, and that's specifically it. It's the citrus pectin that he was talking about. So it was just a thought. If anyone, and thanks, Bob, for the feedback. Interesting that you've been taking it. You said how long you've been taking it?
I was taking it more regularly. I guess I've been off and on for 5 or 6 months. So I don't know if it really does anything. It was suggested to me to get the powder and not the capsules, because the capsules, you need to take like 5 of them to get the recommended dose. So again, I don't do it regularly, and I don't know if there's any way, even if I did, to measure if it does anything.
Okay, well, it's just anybody else have any experience with that?
Uh, yes, Neil. I put something in the chat box, but I'm not sure I copied it well. It's a phase 2 study done by Peter's oncologist, Mark Schultz, and Stephen Strum, who used to be in Mark Schultz's group. It's kind of an old study, and they did demonstrate a PSA, a reduced PSA doubling time in men with prostate cancer. See if you can click on that. I'm not sure. I don't think I may need to recopy it and paste it.
Yeah, I can't click on it. No.
You can? Okay.
No, I cannot.
Oh, you cannot. Okay.
No, but I think I saw this one. It was from 2014, and I
Yeah.
think it was done in conjunction with the gentleman, the doctor from Israel. I can't remember his name right now.
Yeah. So he's here in this country, but he manufactures the pectin. So
Yes.
he's not exactly independent. Len, you put that it increases the doubling time. You mean it decreases the doubling time? I suspect.
No. Actually, increases would be correct, right? The longer the doubling time, the
Oh
better.
yes. Sorry, yes, you're correct. You're absolutely right. Yes. So it
So
increases.
try that now, Neil. See if you can click on that. I pasted it in again.
No, you've got to
The
put
link,
in the actual. You have to put
No.
in the URL, Len.
yeah, the link doesn't work. The other thing is I
Okay.
get it from a company called Swanson, not the guy who did the study who sells it himself.
I see.
Yeah.
So there's more manufacturers than just his.
Yeah.
Now I looked at this a while back because this pectin's been around for a long time, and it seems like the reason it works is that it decreases cholesterol. So I mean that I try to figure out what the heck is it doing, and I think I sent Neil the pectin link that's on the Memorial Sloan Kettering vitamins and supplements. So then the question is, well, statins another alternative. I suppose, though, in the theme of tonight, one could say, well, this is a less toxic version of the statin. I don't know what can anybody explain what the pectin does? Why it works?
I believe it binds the cholesterol in the GI tract.
Right, that's it. Thank you. Yes. So, the other issue is using a diet that reduces cholesterol. I mean, I don't know. It's certainly not a magic potent potion for people with advanced prostate cancer. It may be preventative. The other issue, which I included in this week's reminder, that meta study on quality of life, and the conclusion from that meta study was exercise definitely helps, diet may help, and supplements don't seem to do anything at all.
Right.
Did you see that link, Neil?
I did. Yes. Yes, and I read that in exactly those words. I think diet and exercise.
So I don't know. Anybody else taking pectin other than Dr. Bob?
I've been taking it for Crohn's disease,
Aha.
which is it binds. I just learned about it actually from my new GI doctor down at Sylvester. But I haven't. I haven't taken it regularly, and I really can't tell you if it's working for Crohn's. But but I was told that it does, and it can't hurt. So that's why I'm taking it.
I'm taking it on the same basis.
Is it helping you, Pete?
I have no idea.
Right.
I thought it might help.
Yeah, it goes under the category of supplements again.
Right.
Gary.
And it can't hurt.
That's right.
That's it. Well, thank you very much. That was all that I wanted to say. Thank you.
Well, Rick, believe it or not, I believe we've covered everybody. Does anybody have any comments, questions? Look at that.
Well, I wanted to thank y'all for everything you do every week. Thank you very much. That's all I wanted to say. Thank y'all for real. I mean that.
Okay.
We love you. We love you, Henry. Thank you very much.
Y'all been the best.
Really great discussions tonight, huh?
Yeah, it's interesting. You see what happens when we don't have any new people. So new people take up 40. They take up the first hour one way and the other, and we do have a lot of time for everybody. A few people came in late. Anybody who came in late? Joe Commander, you came in late. Anything for you, sir? Who was it you met? Didn't you and Joe Gallo have
Yeah, we had lunch. We had lunch together last week, and that was very nice. We'll probably do it again. He lives probably 10 miles away, maybe less.
Oh, great. A couple of things coming up that are, since we have the time, I'll just give them a push. Any vets on here? We've got a vets art class coming up, which we got money for to send out supplies. So we're going to send out watercolors to everybody. And if you're a vet, if you're a friend of a vet, if you want to do it with your grandkids, it doesn't really matter. We're not going to ask to see your dog tag. Dr. John, you and Ray are included because you worked with vets for long enough, but you got to. We pushed it out till June 21st, but we need to know because we got to send you the supplies and they take time to get to you. So anybody who fancies doing that class, you're very welcome. We've got the webinar coming up that you have seen that Len and Dr. John are going to host on PARP inhibitors, which should be pretty interesting. I am frankly pretty confused on these PARP inhibitors. I was of the opinion that they only worked if you had a BRCA mutation, but now I've seen a few other things that suggest maybe that's not 100% right with the PARP inhibitor alone. The FDA thinks that when you combine it with abiraterone, you got to have a BRCA mutation. Not quite sure what's going on with talazoparib, but I'm sure Dr. Shaw's going to tell us. I don't know that what he says will be exactly the way that Dr. Munster sees it, so that could be fun. I don't know, Dr. John, you're the Talapro expert, right?
Well, it's like you say, it's confusing, so it is going to be really interesting.
Yeah.
I mean, I don't know why Talapro 2 worked out the way it did. They can explain it to us.
Well, Dr. Munster said she thinks it's in the trial design. So I don't know. So there's a clue for you Brains Trust guys to check out the trial design and how they're reporting it. That comes from the horse's mouth.
Yeah.
Hey,
So
Rick, I wanted to say thank you to Lynn. Actually, about a month ago, recommended that I look at olaparib, and that's a PARP inhibitor. I mean, I just think that's the utility of this group among many, many, many other things that we talk about. You know, hot flashes, exercise, etc. But I read about olaparib thanks to Lynn, and when the day comes that I become castrate resistant, you know, that's going to be a thing that I'm going to be suggesting to my doctors that I self advocate for. So I know you get tired of hearing this, but y'all are the absolute best. That's all I want to say. I mean,
no.
I just wanted to remind y'all that. So thank you very
Um,
much.
Henry, make sure you either attend or watch the webinar because it's
Oh,
going to be all about.
it's on my calendar.
Right.
Absolutely.
Yeah. Yeah.
Yes.
Because for people who
Yep.
see olaparib in their future,
Yep.
We really want
10-4.
you to attend this. That's
Absolutely.
really why we're doing it.
Yep. Thank you.
So
Thank y'all very much.
so what else do we have coming up? I think those were the main things. Yeah. Yep. All right.
Yeah,
Well,
let's
that's
give
it.
these folks 10 minutes free time. They can
Oh, we
celebrate.
can. I just want to say one quick thing, which is that I attended the Sartor session before this. I didn't catch the beginning. I didn't see the slides. To be honest, I was finishing up my exercise, and I came on with the questions. I thought the questions were a very high level. I mean, I struggled to keep up with a lot of those questions. And I thought to myself, is that the standard? I mean, how does that differ from what we do here? And I mean, the guys are very, very knowledgeable, but I still feel that a lot of them are chasing their tails and not really. I don't know. I mean, Ben was on there, Len was on there, Peter was on there, Dr. Bob was on there. I don't know. There was probably a couple of others of you. Um, could you see a meeting like that every week? I mean, I'm just interested to hear your feedback.
So
Yeah,
that was,
I agree with you. Some of that stuff was uh, at the professional research level, and I think some of those guys are professional researchers. Um, but like you say, they're maybe chasing their tails because they're talking about things that probably have a low probability of being translated into the clinic. And I think Sartor was trying to send that message to them.
yeah.
Dr. Bob?
I was going to say, you know, meetings like that aren't weekly. It's usually every couple weeks, and it's very variable as to what, you know, this was probably the highest level. And, you know, there are some guys there that are chasing their last, you know, their last hope.
Yeah.
So, you know, you can understand why they're, you know, looking for anything.
Right.
Ben seemed to understand it. I was watching his expression the whole meeting. He seemed to
He was smiling
know
and
it.
nodding quite a lot.
Huh?
He
Yeah.
was. He looked
It was-
he looked like he looked like one of those dogs in the back window of someone's car, you know.
Bobblehead.
No, I think he
Yeah.
found it. So Bob, the thing I didn't understand is how come some people had hands and most of us didn't have hands? Where did that come from?
That's part of Zoom. You just have to find it. It's under reactions.
You had a hand, Peter.
I
I'll
couldn't
call
find
me.
it. I couldn't.
It's under reactions. Where it says reactions, you have to
Okay.
click reactions, and that's where you could have put your
Okay.
hand up.
Okay. I
Okay.
see. Okay.
Look, oh, Jimmy put his hand up. Jimmy, what you got? No, this was on Zoom though.
Yeah.
This was
Similar but
on
It's
different.
just
Zoom.
as easy.
It's just as easy.
Just
It's
as easy.
just as
Right.
it's just as easy. Yeah, Ben sort of got excited when they got into some of these this really weird stuff. Like, you know, I don't know. But we've lost Ben. He's not here anymore. He left. He came in quickly, and I think he's gone.
I
All
thought
right.
Hey,
Well,
Dr.
this
listen.
I thought
wait,
Dr.
hold on.
Sartor's
This is totally off topic. But Jim, I've been looking up Brother Jim and listening to it on my Apple Music thanks to your T-shirt. They are awesome. I can't wait. Your T-shirt, Jim,
Brother
says
Smith?
Brother Jeff, whatever it is.
Brother Smith.
Yes, Brother Smith. Awesome.
They're very good.
So
I
that's
haven't seen them. My
another.
wife went down to Asheville, North Carolina and saw them, and she bought the T-shirt and some CDs. She was so impressed. And she's not easily impressed.
So that's a
So I'm
third
glad you
thing
like
that
them.
has benefited me from
They're
tonight.
really
Thank
good.
you very much.
They're really good. As a Southerner, you'll enjoy them especially, I know.
I've already been. Yeah, the fiddle. It's down, baby. Thanks.
Yeah, it sure is. Down is a high compliment, in case y'all don't know.
I will when we get the recording of the Sartor. When we get that Sartor recording, I'll put it in the reminder so everybody can listen to what went on and try and tease it out. And we've got the slides. We've got his slides, but I'm not sure if they're worth linking to or not. They're a little hard to follow,
his
right,
comment
Ben?
his comments about bat are very intriguing. The way he
Yeah.
he interprets it and wants to experiment with it. I mean, it's great that there are doctors that want to go on their own
Yeah, but
experimentation.
Yeah, but Peter, that's why I asked him the question about durability. And when I said to him, yeah, everybody's talking bat this, bat that, the other, and I said to him, what do you see people get out of it 5 months? And that to me is the bottom line. Do I think bat is yeah, I think it's good, but you have to have expectations. We tell people here, if you get 8 months, you're lucky out of a bat treatment.
Right, but he's not. He's saying something different. He's saying, let's not go up and down. Let's just go up.
Oh, right.
Who knows?
Yes.
Right. He's
Yeah.
talking about resensitizing to
The
enzalutamide, and then I guess you can do it again and again.
Yeah. All right, guys.
All right.
Good night.
Good night, everyone.
Good night.
Thanks,
Good night.
Len.
Thanks, Len.
Good night. Thank you.
Thank y'all. Bye.
Thank y'all.
David, hang on a second. I want to ask you. Hang on, if you don't mind. We'll get rid of everybody, and then I'll have. Oh, we may have to start kicking people out here. Oh, Ben was there all the way along. He never said anything. I don't think he was. I don't know if he was listening or not. Are you there, Ben? All right. Gary Peters. Well, we're gonna excuse. Yes. Jerry Pelfrey, excuse. Yes. Sylvester, excuse. Jerry, hold on. What was that? Sylvester will get rid of. Yes. And Ben, are you there? There's only me and David here right now. I don't think you are. Oh, I should stop the recording. Oh man. I don't know how I can't stop the recording. And if I can't stop the recording, I'll call you. I'll call you, Mr. M, right now because I can't stop the recording. Okay?
Okay.
All right. Bye.
Bye-bye.